Hi, everyone. Welcome to our ICARE Genetics Case Conference for January. Happy New Year to everybody. So I wanted to take a moment to introduce our guest expert who you hear from regularly through ICARE. It is Katie Lang, who's the Director of Cancer Genetic Counseling at Vanderbilt. I have the pleasure of working with Katie a lot. Katie has a Master of Science in Biotechnology from Hopkins and another master's in genetic counseling from Virginia Commonwealth University. She's had multiple awards, the only genetic counseling student to ever be honored with the Charles C. Clayton Award from the School of Medicine, which honors graduate students for both academic and research achievements. I can just tell you that does not surprise me, having worked with Katie for several years now.
There we go. This is not something that I would say I have a lot of expertise in. It was just something we as a team learned about on the as we encountered the case I'm going to talk about, this kind of intersection of germline testing and transplant eligibility. So, or a donor situation where someone is on a transplant list and they have to make very difficult decisions about allocating a very, very scarce resource and what factors go into that decision and how we may feel about that.
And, now that we're on this topic, there's a patient that you had looked into more that I recall where they'd had a transplant and they have Lynch syndrome. And now the question comes up about, I think it's a PMS2 positive case. And the question comes up, should they be screened more frequently as well? So I think really what we're trying to get at is transplant of whether it's solid or liquid may be impacted by germline mutation status. So
yeah, there's a young patient right now who actually incidentally was found to have a PMS2 mutation. She had had a liver transplant when she was 4, has never had cancer, and she was having a lot of other health issues and had a whole exome, and they found this incidental PMS2, although now when I hear about her family history, it doesn't sound so incidental. But the question was, and she is in her 20s. So not at an age where we would normally screen for PMS2, but with what we had learned through the patient we're about to talk about, we found out that the immunosuppression, we don't have a lot of data on the intersection of this immunosuppression and increased risks for patients with germline mutation. So when we asked the GI doctor, he said, yeah, I would screen her annually with colonoscopies, start before the normal age for PMS2 because she's immunosuppressed. So this case was earlier in 2023. A patient was referred for personal family history. All I knew going into it was she had an MSH6 mutation in her sister. The patient was 60. 10 years prior, she had had a stage 1 colon cancer treated. She only required surgery. This was all done at an outside facility. We actually did not have these records, but she had supplied this history. And she herself had COPD. She used oxygen, and she was under consideration for a lung transplant. So this was her pedigree. So pretty striking. Here's the proband. Her sister had recently been diagnosed with breast cancer, had undergone a multi-gene panel, and was found to have an MSH6 mutation. And we did have this report. One other sister had tested negative. No one else in the family had had testing prior to that or after. So, dad did have colon cancer. This was by the patient report that it was genetic colon cancer, but that was many, many, many years ago. So I don't know if that was just something that came up after the MSH6 mutation was found, that they were told, oh, this must be coming from your father. Obviously, the history looks very striking for, BRCA or some breast and pancreatic gene, but thus far in the family, no one had been tested for anything else. So at the very beginning of the session, the patient basically said, I'm here because I need a lung transplant. And when I inquired further, because that's not typically a discussion that we have, she said that after her sister had testing, she told the transplant team, and they said, go to genetics and get genetic testing because we need to know. So that rang a little bit of a bell to me. We're used to having these discussions about patient autonomy and why they want testing and that it's their decision. So this seemed a little different than what, patients are normally told when they come to see us. So I actually didn't feel comfortable ordering testing for her without knowing a little bit more about what was going on with this transplant eligibility. There was this note in her chart that said we will require genetic testing for Lynch syndrome prior to moving forward. So I just said, I don't want to put you in a position that, makes you ineligible for a transplant without you knowing that. So I said, are you comfortable if I go and just talk to your transplant team and then let you know what they tell me? And she said, I'm comfortable with that. So in the meantime, I did a little digging, and some of this is also what I learned from talking to the transplant team, which I'll get to in a second. And again, this is my own research. I am by no means an expert on lung transplants or COPD, but this was sort of the framework that this patient was in, that there's about 4,500 lung transplants performed around the world every year. They are done for a variety of reasons. Her diagnosis would be considered a chronic end-stage lung disease. And the idea is, for people, of course, that are at high risk of death within 2 years and also have a high likelihood of surviving, long-term in this case is only about 5 years after. So certainly there's many, many, many more criteria that go into this, but this was sort of the baseline to even start the discussion. Lots of things, as you can imagine, contribute to survival after a lung transplant. They, on average, what I found was about 74% of people live at least 2 years. However, if you break that down, overwhelmingly, the higher survival is for what they call native disease, which is like cystic fibrosis, so some kind of predisposition, versus, I guess you could call it an acquired lung disease like COPD, where the survival was far fewer. So I will say I'm confused with if there's a 40% survival rate, how that, corresponds to the prior criteria of this life expectancy. So that seems a little contradictory to me. But the bottom line is that this is not the type of transplant that gives you a huge amount of time afterwards. When I talked to the transplant team, which I'll go to I'm sorry, before I get to that. I also tried to look up having cancer and getting a transplant. And generally speaking, a prior history of cancer is not an absolute contradiction for receiving a solid organ transplant. So this is not talking about bone marrow transplants. This is talking about solid organs like kidney, liver, lung, heart. And this paper actually nicely broke down by type of cancer, kind of specific criteria. They actually had a comment about MSI status, that MSI high colon cancers were actually a positive, in the positive column because of better survival. So we didn't have this patient's actual MSI data, but we would, if she had Lynch syndrome and had colon cancer at 50, odds are very high. It was MSI high. And so according to this particular aspect, if a patient in her shoes had a fully treated colon cancer that was either low risk disease and was 1 to 2 years out, or 3 to 5 years out for high risk disease, she was 10 years out from a low risk disease. So that seemed reassuring. So another thing that really I think is kind of the core of this is what I did not know and learned through this process is that people post-transplant are at high risk for cancer, and people specifically who receive lung transplants, cancer is the second most common cause of death after organ rejection. So this is extremely concerning to transplant teams. And essentially, this is because they are highly immunosuppressed. And lung transplant patients are even more immunosuppressed than other solid organ transplant patients. On average, so obviously this is people without genetic predisposition, what I found in the literature was about a 2 to 3-fold risk over the general population. Skin cancer is astronomically higher, 60-fold higher. And on average, there's a 5-year risk of 16% and a 10-year risk of 32%. And most commonly, they are lymphoproliferative disorders, skin cancer, and then some more kind of common solid tumors that we encounter a lot. Interestingly, there is a fair amount of literature out there about Lynch syndrome and transplant patients, not necessarily lung, but solid organ transplant. And almost all of it centered around Muir-Torre and sebaceous carcinomas, which, knowing what we just learned about the skin cancer, extremely high risk, seems to fit. And so there's multiple, these are just a couple of the papers, but there's definitely a good amount of literature out there about people post-transplant developing these sebaceous tumors and sebaceous carcinomas, in addition to developing colon cancers. However, a lot of these were years after transplant. So one of them was like 14 years, 10 years. So if we're thinking about, overall survival with the underlying purpose of the transplant, and then cancer is developing 10 years later or a lot longer, how much should that weigh in to the equation? So I tried to get my ducks in a row, and when I talked to the transplant team, really just I talked to one provider, the kind of lead, and I just tried to understand, why this patient was sent, what their mindset was about germline testing for her. And she was the one who originally told me about this cancer risk, so then I did more digging. The lack of data on her particular gene in the lung cancer, setting, they just were very, very concerned that they felt like it was a gray area. Her actual colon cancer was really not their concern. It was really the future cancer risk. And of course, as we all know, if you Google Lynch syndrome, you see very high numbers. You see, up to 80% risk of colon cancer, depending on the source that you find. And we all know that those are, depending on the gene, depending on the age, depending on prior cancer history. But that's kind of what they had encountered, originally when they looked at Lynch syndrome, these very high risks. And they also had a patient who, we don't know their germline status, but they had actually developed, they had gone through a lung transplant and very quickly developed an extremely aggressive colon cancer that they died from and really suffered through. And this team, I think that was very salient to them, that they had watched this happen. And so I think it was kind of higher on their radar, this kind of cancer risk post-transplant. I did ask about other genetics, rationales for adding someone to a transplant list or not, and they said that they do decline transplants for mutations. They hadn't encountered a cancer predisposition situation before, but in the lung transplant world, they would deny someone if they had a TERT mutation, for example. And what I also learned was for anybody post-transplant, their cancer screening intervals are cut in half. So you get mammograms every 6 months, you get colonoscopies, even more frequently than you normally would. So this doesn't even take into account family history and underlying genetics. So after this conversation, I obviously learned a lot. I did more reading on my own, but I said that I would give the team as accurate a risk assessment as I could of if the patient is positive, here are the risks that we would predict. And then they would take that and discuss it internally and let us know, how they would process that information. So as it always seems to happen in genetics, these things come in waves. So this was not really something that I had encountered necessarily before. And then very soon after, I saw another patient who happened to be on a liver transplant list. She had developed a paraganglioma while she was on that list. So when that happened, she was taken off. And they had a lot of debate around, her treatment and her surgery, and they decided to go ahead with surgery because if they could get a clean margin and and she had positive lymph nodes, then her prognosis would be considered very good and she could go back on the list. And that's actually what happened. So she had a clear resection, and so that allowed her to go back on the list. So by the time I saw her, that had already happened. And she was happy to be on the list and was very motivated to have testing for her children, as many people that we meet with are. But given what I had recently learned, I was hesitant and said the same thing that, hey, I'm going to, is it okay with you if I go talk to your transplant team and just make sure that we are not introducing another complicating factor to your transplant eligibility? And she was fine with that. In this case, they had no concerns. They said, nope, I can't even imagine why we would be worried about that. Now, granted, it's a different set of genes, and therefore there's different risks. But I did guide the patient that, obviously these days, especially in cancer, we have these really broad tests we can order. And, maybe given her situation and her family history was really not suspicious of anything else. So we both made the plan that we were going to order a pretty targeted panel for, paras and phios. We included RNA and she came back completely negative. So in this case, it really was a non-issue, but also she tested negative. So soon after that, we encountered a patient similar to Nicoletta's, a young patient with leukemia. She required a bone marrow transplant. In this case, we checked in again, but they said, we are going to transplant her no matter what because we needed to save her life. So the calculations were very different. And they felt like germline testing would be helpful because it was going to help them, rule out, again, a family mutation so they could pick the best donor. So in this case, the imperative was we need to save her life. This was just information that's part of the story. So I, in this case, used Ask to Me. And given that she had had a prior colon cancer, this was the picture that I got when I put in her age and the fact that the mutation in the family was an MSH6. So I was very relieved when I saw this. She has never had a hysterectomy before. She still has her ovaries, so those risks are there. But otherwise, these numbers don't look like what we often think of with Lynch. They're, 10% and lower. And again, she would still have a risk of a second primary colon cancer, which isn't included here. But internally, our team discussed these, and we all felt that these are very, in the scheme of what we see in genetics, this is a pretty reassuring picture. And the types of cancer or the type of cancer, endometrial, she's at highest risk for, is a treatable, type of cancer with a good prognosis if it's found early. So even if that were to happen, it's different than if we're talking about something like pancreas or something like that. And she did not have an oncologist at our institution because she was treated somewhere else so long ago. But we did discuss this with a medical oncologist, and they said, I would consider her essentially cured from her original cancer, given all of the factors that we have. So I brought this back to the transplant team, and they discussed it. I gave them that exact picture with lots of information and input from genetics and oncology. And they came back and said that their decision was, if she did not pursue genetic testing, she would not be considered for a transplant. If she tested positive, then she would not be considered eligible due to the kind of unknown associations. And if she was negative, she still may be eligible, but it's not a yes. It's all the other factors would still need to be taken into consideration. So here's where I just want us all to, these people have an impossible job, and I do not envy them. And I think this is, just such a stark intersection of, ethical principles, and, patient autonomy, and, putting yourself in, of course, my patient's shoes is very easy, and how, devastating this could be. Putting yourself in the shoes of, another person waiting for a lung transplant who doesn't have a genetic predisposition to cancer and may have a better long-term survival. When you're talking about these finite resources, I just don't envy these people. So I just want to make a little space for that, because this is, hard to hear, to say the least. Given that, I did not feel like it was appropriate for me to be the one to tell the patient this information. So I asked them if they could communicate it to her and let me know, so I could kind of preserve our, clinical relationship, and then she and I could continue our discussion once she knew their decision. And they said that's fine. So after that, the patient and I talked about what to do next. So, when we got on the phone, she, told me that she had talked to them. And on one hand, she kind of figured that's what they were going to say. And I just tried to clarify that there's not, sides here. I'm working with her to help her come to the decision that is right for her. They are not, telling you, just because they are saying we want her to be tested does not mean I am obligated to test her. At the end of the day, I'm going to do what she wants to do. So we talked about this a lot, and she, in the end, said, I want to do it. I want to remain eligible, because that was the only path to staying possibly eligible. And I did emphasize that she was a very, technically on paper, she has a 50% chance of carrying the variant seen in her sister. Given that she had colon cancer, the odds are very good that she had this variant. And then looking at this history, I kind of struggled with, well, all of this discussion was around this variant in her sister and Lynch syndrome. The family looks like BRCA, or a gene in that pathway. And so normally you would see a pedigree like this, and you would say, you would have a list of genes, breast genes, pancreas genes, colon genes, a no-brainer. But in this case, is that going to put her, what if she's negative for MSH6, but then positive for something else? But also you don't want her to miss out on knowing what she's positive for. But if we're trying to, spare her the removal from the transplant list, can we get by with, minimal testing? And so it was just a very complicated and heavy discussion. And so we weighed the different approaches. And then, of course, the dreaded VUS, like with all of the hesitation about uncertainty already in this case. How are they going to handle a VUS, no matter how much science we throw at it about what VUSs mean and what they don't mean? So do we want to minimize as much as possible getting a VUS? So actually at first we left the visit and she said, I just want to be tested for MSH6 and then we'll kind of revisit from there. And I said, okay. And then she actually called me back the next day and said, I want to provide as much information as I can for my daughter. And I think the right thing to do is to be tested for, the major genes we're suspicious for, and I emphasized to her, your daughter can be tested for whatever she wants to be. If we really want to, yes, normally we say test mom before you test daughter, but given all the variables here, I said, if your daughter wants to be tested, we can still help your daughter. But she said, no, I know that the right thing to do is to test me, which I don't want to get emotional, but was just so touching. And she was putting, herself on the line for her daughter. Sorry. She tested positive. We still kind of drilled down to like the bare minimum genes, Lynch, the kind of, pancreatic, high-risk pancreatic. And she carried the mutation in her sister, nothing else, no VUSs. And she was not eligible for a transplant. She is still with us. Actually, last I saw, she was going to another institution for a second opinion, to see if they would consider her eligible. So during this case, I, of course, posted on the Cancer Sig, and Madeline Graff, I don't think she's here, is a genetic counselor at Stanford, or at least was when she published this paper, and she reached out, and some other people did too, and they helped me identify some of those papers I listed before. But the best, this was the best study I could find about this whole concept of utilizing, germline testing in organ transplantation decisions. And it was in the pediatric setting. And it looked at liver, heart, and kidney. And I think what's interesting is that there is absolutely no consistency. And it is not always a yes and always a no. So a lot of the programs that did answer said that they have required genetic testing for specific indications, so 64%. 16% said they use it even without a reason. So they would essentially use it to screen people out, even if there wasn't an indication, which on one hand is almost more equitable, you could say, like if you treat everyone the same. Because one thing that we kept coming back to in our own discussions was, it's one thing if everybody gets a thorough family history and eligibility for germline testing is determined. But in our case, the patient had volunteered this information because she was an honest person and probably without knowing, what the implications would be. And so would patients hide this information, if they got wind that it could, be used against them in this way, or I shouldn't say that, but be used in these decisions. So there were some interesting hypothetical scenarios given, and they used, BRCA1 as one of them. So this is in a child. So the hypothetical patient was between 18 months and 4 years. And 8% of centers would consider that a possible contraindication for an organ transplant, even though it may not be related to anything of why they're doing the transplant. Where with the TP53 variant, 61% would consider it a contraindication if the patient had a mutation in one of those genes. Only 3% of the programs had any kind of formal policies. All of them said they sometimes consult genetics, but more reassuringly, 55% said they would always involve genetics in testing for these scenarios. So that tells me that this is happening. like with many areas, we just need a lot more data.
Katie, thank you. That was really fantastic. I think we all learned a lot from Katie's research and expertise, and we will talk to you later. Thank you.